Very much for inviting me to speak today. I actually did my PhD at the RPMS before I came to the Claw Lab, and I had the pleasure of working for Professor Cawthorne for a number of years before he passed away last year. So I'm not a clinician, sorry, I'm a biochemist. So I'm just going to talk to you a little bit about some of the preclinical work that we've done at the Claw Lab and some of the lead targets we've taken through into the clinic. So we all know that diabetes drugs lower blood glucose per se, but very, very few of them actually do it long term in any individual patient. We know there's huge individuality in terms of responsiveness to class, and to reduce the risk of long-term vascular complications and minimise the adverse effects takes quite some juggling in the clinic. So as a whole, individually, most classes of glucose-lowering drugs don't have a substantial effect. They're all quite similar when they're used individually, but it's actually the combination which is really important, and often it's a best guess approach in choosing the ones that you want to use. So we're constantly looking for new classes, new targets, and potential new combinations of therapies going forward. So, but we have worked on serendipity to date. For example, we've had the use of a fantastic compound in metformin, which is actually derived from a plant, and we had the onset of the sulfonylureas, which have been used to lower blood glucose for a number of years. And we've also seen the marketing of a number of new agonists, for example, GLP-1 and DPP-4, and I'll touch on a bit about that, how they've been developed a bit later on in the talk. So I think it's important to realise that whilst this session is focusing on type 2 is only one of a number of different types of diabetes. And we mustn't forget that actually there's quite a strong genetic component, for example, in MODY, and also in this early onset diabetes in babies. And that's actually something that we've been looking at a little bit in further research programs in our fetal origins program we have at the lab. So to date, I think that the stats, there's about 347 billion people that have been diagnosed with diabetes, and I think that probably there's about 46% of people that haven't yet been diagnosed. And a very famous scientist, Professor De Fronzo, he described it as this orchestration between three components, which was impaired insulin secretion, hepatic glucose output, and insulin resistance. And these three come together in this trio, causing impaired glucose tolerance, resulting in type 2 diabetes and the associated complications. But it's not just our lifestyle, there's also this genetic component which we also must keep considering in the back of our minds. So while there are some individuals which can be predisposed to type 2 because of a genetic component, some individuals are also actually protected by it. And in actual fact, the actual percentage of people with these morbid genetic diseases, that's actually really quite a small percentage in the overall population. But we know now that it's not just the pancreas and the liver, that actually there's this, what De Fronzo calls this ominous octet, if you like. So it involves adipose, the kidney, this incretin effect, so that's coming from the intestines, obviously the alpha cell, the beta cell, and also neurotransmitter dysfunction. So that's, we now know that the central nervous system actually is incredibly sensitive to changes in glucose and insulin resistance. But I think one of the most important things when you're looking at the natural history of type 2 is that in the clinic, when we diagnose people, they're actually at the peak of the curve, where they've got this very high level of glucose, but in actual fact, it's at a time where the insulin levels are really low. So in most patients that are diagnosed with type 2, they probably lost about 84% of their islets. So we're probably looking at a position where we're almost looking at an irreversible position. So I think we must be quite mindful in terms of when we diagnose and how quickly we diagnose these people. So this then brings me on to thinking about the different classes of drugs we now have available. So I said before, we had the thiazidinediones, we have metformin, but now we have this luxury of having new classes, for example, the GLP-1 agonists, the DPP-4 inhibitors, and the SGLT2 inhibitors. And we're now understanding from different algorithms originally proposed by De Fronzo that actually combinations of these plus lifestyle changes might be the way to go, as alluded to by Professor Krentz. But But the drug discovery pipeline is quite complicated. I'm sure you're all aware that you start with a clinical idea, compound screening and candidate selection, and then you have these 4 phases of clinical development, ending in overall marketing. But the cost of taking one drug to the market, I think, is now about $1.75 billion, because that includes all the money that's spent in developing the other programs that come through with the lead development. And the preclinical phase, which is something I just want to allude to in the next few slides, is something that's quite complicated. It's quite controversial at times with some programs, and there are a number of issues which Big Pharma have to take into account. So I think, if I'm correct, that it's 1 in 24 programs go from a target to a successful program, and you have this U-shape effect of programs. So you start off with a large number of targets, it then decreases until you've got good proof of concept, and then the number of successful programs, they've got a higher chance of succeeding, even though the actual number of successful programs going to the market decreases, if that makes sense. So it sort of tailors off. So in the Claw Lab, we've been working on preclinical models for nearly 25 years. I haven't been working for 25 years, the lab has. And we use these to really look at proof of concept. So we're very interested in taking compound libraries, screening them across these preclinical models, looking at their efficacy, bioavailability, some toxicology, and their PK and PD. So the rodent models which we use fall into 2 main categories. So these are the pre-diabetic ones, which are characterized by obesity, insulin resistance, and glucose intolerance. So these can be induced in animals by feeding them a high caloric diet, so a diet high in saturated fat and high sugar. They can be mutant models, for example, the leptin, the OBOB mouse, and the equivalent in the rat, the Zucker rat, and also in a number of ranges of knockout animals where a specific gene is knocked out and gives a physiological metabolic phenotype. You've also got diabetic animals. Again, these are characterized by insulin resistance, predominantly hyperglycemia associated with pancreatic failure. And other examples of these mutant non-functional leptin receptor. So leptin is a satiety cytokine. It's also involved in energy balance in the brain from the adipose tissue, and its equivalent, the Zucker diabetic fatty rat. And again, in a number of other knockout mouse models. So we're particularly interested now in using some of these preclinical models to try and dissect new compounds. So one of the programs we're looking at now are the free fatty acid receptors. So these free fatty acids are involved in the sensing of medium, short, and long-chain fatty acids in the gut. And our interest really stemmed from work we'd done previously on GPR40 agonists. So GPR40 is one of the free fatty acids. And it came with the removal of TAK-875 from the clinic due to toxicology effects. So we thought TAK-875, before it was pulled through tox, was actually a fantastic drug. And we're now looking for chemical series and natural agonists that we can use to replace TAK-875. So we're thinking about taking that initial lead structure, if you like, and seeing what other analogues or structural changes we can make to the series that we can take forward into our preclinical models that don't have the adverse toxicological effects. So we've really focused our attention on GPR40 and GPR120. So both of these are receptors for medium and long-chain fatty acids. And if you agonize them, so if you stimulate them, you have increased glucose-stimulated secretion from the pancreas. That's associated with whole-body insulin sensitivity. You have an increase in energy expenditure and a very profound stimulated incretin effect, okay, particularly at GLP-1. And as an additive, GPR120 is actually now shown to be anti-inflammatory, so an added bonus. So we're looking for molecules that preferentially stimulate them both. So we're looking for molecules which can agonize both 40 and 120 in the same chemical structure, because that's a very positive profile. And we're looking at this in both preclinical models, but also in euglycemic clamps in obese patients, and that's being carried out in Copenhagen. So as I said, these potential new co-targets actually could be very interesting clinical targets going forward, particularly if we can find them in naturally occurring compounds, for example, some sort of nutritional supplements, which is something we're looking at now in the latest, I'll show you in the later slides. So this slide really is just showing some of the compounds which we've developed based on the TAC structure. So GPR40 actually isn't expressed in the liver, so it's not an actual direct effect of GPR40 agonism in the liver. So we haven't used the TAC875 structure because we believe that's where the problems are lying. So we've developed compounds around these structural analogues. But one thing we have found is that pine nut oil, which is actually taken from Korean and Siberian pine nuts, actually does the same thing as these synthetics and actually agonizes both GPR40 and 120 extremely effectively in our models. And that could be really important as a clinical target. We've also spent more than 10 years working with a company called GW Pharmaceuticals, looking at cannabinoids and the cannabinoid receptors. And that was really our interest was really invested here because of rimonabant being withdrawn from the market, because it crosses the blood-brain barrier and causes suicidal ideation. We've now been involved in taking two of GW's compounds through to phase 2 and phase 3 trials. And the compounds in our preclinical models have shown improved insulin sensitivity, increased energy expenditure, and importantly, a suppression of appetite. And just as a proof of the way and how powerful some of these preclinical models can be, the Claw Labs has collaborated with over 40 companies in the last 20 years and run over 345 preclinical in vivo trials. And we've been involved, obviously, in the development of the TZDs, importantly, the GLP-1 receptor agonists. So one of the compounds which we developed was sold to Ipsen and entered phase 3, the DP4 inhibitors, and also the glucokinase activators, which for Precision and for Eli, was then sold on to Eli Lilly, and has gone into phase 2. So overall, I think that the diabetes classes that we have limited efficiency. They all do lower blood glucose and HbA1c, but to a similar effect. There obviously are associated tolerability issues, which we still need to iron out. They're based predominantly on our data from how the patients respond to them. But there is a real need for a new class of drugs that have better tolerability and, of course, cardiovascular outcomes. And it's now coming to light that looking at some of these co-agonists. So, for example, there's a very eminent professor in Germany, Matthias Chopp, who's been looking at combinations of glucagon with estrogen, for example, in terms of these co-stimulatory molecules where they touch the receptor and they activate both pathways very efficiently. So I think there's certainly huge mileage in what we can do going forward, and I think these are quite exciting times for us. Thank you.